Hello, everyone. Good morning. If you want to start filing in, if you're outside, I'll introduce our first speaker. All right, well, we're looking forward to this exciting day. Thank you all for being here in the morning. So the first speaker that we have today is Andrea Patenaude, and it's my pleasure to introduce her. She's a clinical and research psychologist at the Center for Cancer Genetics at Dana-Farber Institute. She has conducted research on the psychologic aspects in cancer genetics since 1994, when she worked with Dr. Judy Garber and Dr. Li with the first studies of families that were undergoing genetic testing for Li-Fraumeni. At Dana-Farber, she works closely with genetic counselors, and she has a clinic where she sees members of hereditary cancer families and works very closely with a multidisciplinary team. And one thing I learned about her, I'm a genetic counselor, and she told me that when she entered high school, she at first wanted to be a geneticist, so that was very cool. So it's my pleasure to welcome Andrea and enjoy her talk.
Thank you, Liz, and my thanks to the organizers of this meeting, not only for inviting me, but also for creating a space to talk about the psychological issues that go along with coping with Li-Fraumeni syndrome. Having cancer diagnosed is challenging enough. It really is the beginning of a long, long journey, and for hereditary cancer families, even a longer one. It means entering the challenging world of medicine and navigating around a world which is completely strange, multiple tests, themselves uncomfortable, painful, and a focus of fear, waiting for the results, and then hearing words that you never wanted to hear. Your child has cancer, or you have cancer. And when the question of whether the cancer might be hereditary is raised, a whole new group of questions open up and a whole new group of challenges. Gathering the family history can be enormously difficult. It may mean telling people in your family things that you can hardly say yourself and think yourself. It may mean contacting people who you don't talk to from one year to the next. I mean, we all have family members who are somehow distant or estranged, or we don't really have much heart-to-heart communication with, and having to talk to them about who's had cancer and what was that really and what did grandma really have. And we encounter family secrets sometimes, people who don't want to talk about this, or this person was not really related in that way. And there are many differences in terms of the openness to talk about cancer in different families, different ethnicities. We'd heard about stigma yesterday. And meanwhile, it's really hard to know, what to wish for. Is there an explanation of the cancer from the hereditary basis, or are we free of that? And it is different for parents whose child is diagnosed with a hereditary cancer. When a child is diagnosed with a cancer that's not hereditary, I often think the second question, besides, is my child going to die, is what about my other children? And parents can be, in the situation of non-hereditary cancer, can be reassured that it's very rare, that it's very unlikely that anybody else among their children would be at risk, and they can breathe a sigh of relief at least about that. In hereditary cancers, that's not the case. On top of their fear about their child who's just been diagnosed is fear about whether their other children carry the mutation and will develop cancer in the future. Parents can be focused on the child with cancer, as well as trying to meet all the obligations at home when it's just a hereditary cancer, but when just a non-hereditary cancer. But when there's a hereditary cancer, there are really many things at one time that are taking up their time and attention, trying to think about whether their other children should be tested, can be tested, when that could happen, and often that can't happen right away. So it's a lot of anxiety on top of the already very difficult circumstance of having a child with cancer. Most parents when there's a question about testing children, are, will at least half will pretty automatically say, yes, we want to test our child. Some feel like it takes a while longer, and there's a small group where they're really not even sure they want that information. And they're worried both about causing pain and fear and distress, or being able to bear the amount of worry and concern that the second diagnosis or second mutation would bring. And there are concerns about insurance. We are lucky in the United States to have GINA, but even that does not take away all the concerns, and we'll talk a little more about that later. And there are lots of communication challenges. Even with physicians, there are many who really don't know very much, and I'm sure all of you have encountered someone who didn't really know very much about Li-Fraumeni syndrome, where you wound up being the person who had to tell them about it. As somebody said yesterday, even how to spell it. And I think Amanda said it, I think, on Wednesday. And that's very difficult. It's a real burden, and families are often very relieved when the opposite happens, when they come to a provider who really knows what hereditary cancer is all about. And with employees and colleagues, it may also be more difficult. If your child has been diagnosed, but there's concern that you yourself may be carrying this mutation, it may be harder to talk to your employer. You may be worried about what they're going to think about whether you're going to get sick and what the issues are for you. So it may not even be as easy to tell them and to involve them in all of your worries and concerns. And certainly talking to the children in your family, again, has another layer of concern, because siblings very often say, well, does that mean I'm going to get cancer? And the answer to that is more complicated often when there's a hereditary cancer involved. And while we know that it's frightening for patients, I thought it was also quite telling when I was recently reading the checklist manifesto by the doctor and author Atul Gawande, who writes about end of life and other things and very difficult things, but he referred to this condition as a nightmarish genetic condition called Li-Fraumeni syndrome, which causes inheritors to develop cancers all over their body. And I think it was very telling. I think it is frightening for not only patients, but also for the doctors who are particularly unfamiliar. There are many griefs involved in Li-Fraumeni syndrome. First, the loss of a child's health or loss of an adult's health, and also even of the belief that just this one case of cancer, and if we get through it, then we'll be okay, or we can start to breathe more easily, but with the knowledge that there may be others involved and other risks and other cancers down the road. It's hard to think of a time without cancer in the future, and it may take away a sense of relative safety that was there before. And then, of course, the challenges and griefs that come with the loss of any particular family member, which may be very difficult to deal with. In terms of how much distress has actually been measured, I would say first that I'm not sure we have terribly good measurement tools for measuring distress in the circumstance of the year in, year out living with something like Li-Fraumeni syndrome. But in terms of what we have found, it's that probably about a quarter of people score into the more clinical ranges of distress. We know that part of that comes from the life experience. The first statistic here is really quite daunting, that by the age of 21, a quarter of people in Li-Fraumeni syndrome families have experienced the death of a sibling or a parent, and that's very high statistic, and and within it lies a lot of inherent long-term distress. So again, about a quarter of some families studied in the Netherlands had found significant distress, also correlated in a different study in the US with the number of relatives who were affected. And it's also that mutation carriers who don't have cancer in some ways actually sometimes feel less able to cope and have more distress. And this is not so different from what's been seen in the BRCA1 population. The mutation carriers who don't have cancer often experience more distress than people who've been through cancer who were found to be mutation carriers. Partly, I think, having experienced cancer, you at least know what it is, and that you know that you have been able to cope or have coped. And when you don't have the disease that you're at risk for. It can be very daunting, and recognizing that if it's lurking, that it may very much change your life in the future. And in terms of seeing, you're differentiating yourself and others in terms of grief, one of the things that happens is that along with thinking about how similar you are to the people you've lost, you also think some about how you're different, and you go down a different path. But if the path is also colored by the same issues, the same mutation, the same fears, it may be much more difficult to let go of, and the grief itself may not go away as easily. There may be more losses in a short period of time, which in turn also makes it hard to move on and leads to increased distress over a longer period of time. As we heard yesterday, the increasing complexity that comes with panel tests, the fact that it's still hard to know when a mutation is found, what cancers may be in the future, when they may occur, is also a source of a lot of uncertainty. And we know that uncertainty is one of the hardest things to bear and the source of a lot of distress. There are lots of tests, the genetic tests, the genomic tests. There are many ways in which you can get new information. The question sometimes is, what does that new information mean? What does it really tell me about me or my family or the future? The screening and surveillance, should it be for everybody? Where do I have to go to get it? What will it do? Will we be able to do this every 6 months or 12 months? And how much is really preventable? The longer that people live, the more risk there is for additional cancers, and that in itself can be difficult. Also, as we saw yesterday, as there's more information, there's smaller and smaller groups of people. There's somebody with this mutation or this particular modifier, and it may separate people so that people may have different treatments or different prospects, and that in itself can sometimes be difficult. One of the early cases that Judy Garber and I saw was in a family where there were 2 sisters who came, and one was positive and one was negative. And they said, before it was us against the world in our family, and now now we're different from each other, and that makes it hard, actually. So there are psychological consequences often in ways you might not suspect. Also, as we talked about yesterday, typically it was families with very significant family histories who were being diagnosed, and so they came with some awareness that cancer might be running in their family, and now we are finding cases simply on the basis of a child's diagnosis, for example, where there may not be much family history, and they may not have thought about cancer very much. So in those cases, the shock may be even greater to find that they carry a hereditary mutation in their families. In terms of screening, this is obviously opens many new arenas to find cancers early. There was a study in the Netherlands, and they found that 71% were given the correct information about needing screening. Of those, about 75% were fully compliant. And the ones who were not said, well, sometimes they didn't really believe a screening could be useful, or they didn't have any symptoms, so why should they go have the test, which is sort of the opposite of the point, obviously, but still it speaks to the fear of finding a tumor. It's one thing to go have a test when you're pretty sure it's going to be negative, and it's another thing to go when there's a high likelihood that something sometime might be found. It's a lot harder. And some of it is simply the hassle effect, having to go, having to plan the time, and so forth. This is a case that there is a case study that was published in the Yale Journal of Biology and Medicine, and it's one of the few things, the only thing really in the literature that talks at all about in the psychological aspects of screening. And so I pulled it up and put the history in here, and I was sitting here on Wednesday evening as we were going through the history, and I realized that the case example that I was planning to tell you about was Amanda. It was sort of like the avatar coming out of the screen. And so you know this family history, but But I would still like to not go through it, but go to some of the implications that her amazing story leads us to. So clearly, the idea that there are both benefits and burdens of screening, and that's actually in the title of the case example, that there were things that were found at very early stages, and that the lessons learned were that these cancers were diagnosed at early treatable stages, and importantly, that there were healthy intervals, and not just healthy, because it was incredibly impressive to hear about the marathons that she was in and to see pictures of her rock climbing. This was good quality of life that was in between, and frankly, not all of that came through in the article, but it certainly came through in Amanda's talk. Also, that prevention was possible. There are things one can do, that one can do prophylactic mastectomies and tamoxifen that may actually prevent cancers from happening when we do screening and when we know what the mutation is. And that there is a significant trade-off, I think, is also an important lesson, that there are psychological burdens that go along with the benefits in terms of early detection and avoidance of chemotherapy or other things that can be done when we find cancers early. But there can be false positives, there can be just being tired of screening, and there is a quote in the paper that talks about her having felt some exhaustion about going through this so many times and wondering when enough was enough. So I think it's important as we go through the new treatments and the new techniques to really also recognize the psychological burdens that may be there on families. And the authors concluded that that all patients with hereditary cancer should be counseled about the benefits and burdens and should be offered support and psychological counseling for possible emotional distress. And I would really like to underline that. I think if we thought there was a side effect, for example, that happened in the knee, we would be calling in orthopedists immediately to take care of, say, the 25% of patients who might have significant psychological distress. But when the side effect is psychological, it's often thought of as kind of a luxury, or maybe we don't know whether there's really somebody there who can help us. But I think we need to think about building in psychological services to hereditary cancer clinics so that people have a place to talk to people who are knowledgeable about their condition and who really can offer support at the times when there are dips in confidence and increases in distress. I think there's also a need to recognize that this is lifelong access, that being able to go back to a genetic counselor who knows you or to a clinic where you're known can be enormously helpful. And social support is very important. It really is the one thing that counters some of this distress. And not everybody accepts the psychological counseling. There's still some stigma attached to that as well. But it is important to try to offer psychological support to the extent we can in ways that are easy to access, because we don't want to leave patients with the burden of finding someone who can help them with these issues. And it's also not just the family members who carry the mutation, but it may be the spouse of the person in the family who has difficulty dealing with all of this. And I think some of the issues in terms of why may be hard to talk about the illness. There can be just the anxiety. And I thought it was also interesting that one of the things was that there were arguments about non-adherence to screening, that your spouse may be the one pushing you to do what you are supposed to be doing, and it can really cause difficulty in the family as well as the actual illness and hospitalizations. So there are many things we need to know about family members with Li-Fraumeni syndrome. There's really very little natural history information about what's it like to grow up with the knowledge of this hereditary risk in your family. How is it best to explain this to children? What can we learn about what's been good and what's been hard for kids to hear? Is it useful to have one-to-one connections with somebody else? I think we have pretty good examples here at this meeting that there are real benefits that come from meeting other people who are dealing with the same rare condition. But does that work for everybody, and how do we set that up for people who may not be joiners of organizations, such as the ones that are supporting this meeting? What about the reproductive options? When is it best to talk about those? And also something we found in our work, which is that one has to be somewhat careful about the discussions, for example, about pre-implantation genetic diagnosis, that sometimes there's the message that seems to get across about you must go to all lengths to make sure you don't have a child who has this terrible condition. And I've seen people who are living with this condition kind of flinch a little bit and think, my life is worth living, and if my parents had made that decision, I would never have been born. So I think one has to be sensitive in those discussions to the fact that that there are identity issues that are connected here that one has to take into account. Issues about dating, when do you bring this up with someone you're going out with? What does it mean for marriage and childbearing? All big questions. And how do kids cope with screening? What does it mean to be going to get annual MRIs when you carry a mutation but have never had cancer? Can kids differentiate those things when a sibling who has cancer has similar tests? And how can we help reduce the distress that kids and parents have going through this process? This is what we were talking about before. These are all very individual decisions, and it's, again, important for someone to get to know a counselor, whether it's a genetic counselor, a psychological counselor, to have a sense of what are the issues for this particular person. So this was just simply saying that the partners were very much in favor of there being psychological counseling available for them as well, that they are often in a challenging position and sometimes can be forgotten as the family member who doesn't carry the mutation. We need research on the emotional impact because there also are strengths that come in families that people can point to, life perhaps becoming more valuable, and being able to share these difficult times can also strengthen relationships as well as threaten them. So there are ways to encourage that, and we need to understand best how to do that. The friendships, social support, again, very important. In a paper by June Peters, the quote, LFS encompasses everything. It's not just physical. In fact, it's probably more emotional. Again, a reason for having psychological consultation in our clinics. This paper, too, talked about how the spiritual and religious support can be helpful. Although not for everyone. A third had no religious or spiritual connection, but those who did have formal religion found great help in terms of the solace of prayer, in the social involvement with others, and some people went back and forth. It was hard for some people to cope with how could God do this to our family, and then perhaps later on might come back and feel, well, no, that was wrong. There are other ways to think about this. And for others, there was relief in being out in nature or having a spiritual connection. Sometimes it's grieving together that brings people together, the notion that other people can help us get through the toughest moments. It is difficult to do research in this area. We still have very small numbers, even though we've talked about how the incidence is certainly greater than we thought it was, but it certainly requires the international collaboration that we have seen and heard a lot about yesterday that was very heartening, to be able to really understand the variety of experiences that may occur. There's a broad age range, so it's challenging to do research, but it's important that we begin to start doing some and understanding more about this psychological side of things so that we can better support the families we treat. And this is also, I think, something which was very obvious yesterday. It was really wonderful to hear about the banquet of potential treatment options that were talked about yesterday. And on the other hand, I was certainly thinking that probably everyone here was also thinking, will it happen fast enough? Will it be here in my lifetime? Will it help my child? And I think that tension is what drives the scientists, but we also have to recognize that it is part of the burden that families bear as well, the hope that this will happen so that their children can benefit from it. And I think we all heard David promise us that if we all work together, we will get to the end and find the treatments and the cures. And I certainly hope that that is the case. And not that this prayer I actually first heard Eleanor Roosevelt talk about as something that had helped her in her life. And it is basically to understand the things you can change and the things you can't change and the difference between them. And I think for what can be changed, action is helpful. And I think that's part of what everybody's being here today and this week has meant, understanding, doing advocacy, contributing to research, getting care, including psychological care. Those are all actions that can be taken that can be helpful to individuals and families. But there are also things that can't be changed, or at least can't be changed yet. And for those, it really is important to be able to put some of the concern and worry on the back burner, to allow yourself to be distracted by good things and by taking yourself as far out of the worry as you can, living in the moment, finding some inner peace, and supporting each other. So thank you. Your time. Questions? Comments? Okay.
Good morning, I'm Larry. I have a quick question. Are there criteria that help you to define what clinical psychological distress is?
Yes, in terms of sort of thinking about the extent to which the anxiety or worry interfere with your daily life. I think that's probably the easiest thing to think about. How does it interfere with your ability to work? Does it interfere with your ability to relate to people in your family? Does it interfere with your sleep? Does it keep you from feeling close to other people, that sort of thing? I think there are tests and measures one can do to assess that, but that's essentially what they're looking for, the degree to which it gets in the way of living your life normally. And when you feel like that's happening, then it's good to seek help and talk to somebody about it. And if you're concerned at all, it's probably better to get some help. Again, many people aren't necessarily experiencing what might be called the clinical level of distress or depression, but it's a low level. It can be a low-level, continual burden that perhaps talking to somebody can help take away or diminish.
Hi, Andrea. I'm over here. That was wonderful. With so many medical things going on at every visit, I wonder if you have any advice on how people could bring up to their doctors if they do have some issues that they want to talk about, maybe family issue, maybe marital issue, something like how do you break the ice from this screening test, blah, 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 to, this is more personal now. Do you have any?
Well, I have many. I could just talk about that for a long time because I think part of it is educating the physicians that this is an area that should be on the list of things they ask about, so that the burden is not all on the patient to bring it up. Some of it might be having something that people fill out in the clinic about their distress, so that gets handed to the doctor in some way, so they have something that they can look at quickly and say, oh, these are concerns. I think the only other thing is to say, I think there's one other thing we want to talk about, or is there someone here we can talk to about some of how this is affecting our family? But having somebody in the clinic, having a social worker or a psychologist in the clinic who people routinely see would be enormously helpful, because then people don't have to bring it up. If there's nothing they want to talk about, fine. They can say, no, I don't really want to do that today. But I think it's a matter of making it part of the environment, and also making it easy and making the physicians aware that this is a piece of Li-Fraumeni syndrome is just as important as some of the other symptoms.
Thanks so much.
Hello, just one more question. I'm actually from Brazil. I loved your speech. It was great.
Thank
I
you.
have so many questions. I'm interested about it, but
We
I'll
can
focus
talk.
on only one question. About the international cooperation. Are you going to come to Brazil? We have a lot of cases. Please come. It would be
Well,
great.
I've been to Brazil and I enjoyed it very much.
Please.
But I'd be glad to talk to you about
Okay.
about it afterward and
Okay.
think about things that maybe I can help from here even.
Okay.
Sure.
Thanks.
Thank you.